Colleagues, ladies and gentlemen, it's a great pleasure for me to have been invited as a radiation oncologist to this very highly distinguished meeting, and I would especially express my gratitude to Reinhold Knecht and his excellent crew, I must tell you, on behalf of, I think, all the participants of this meeting for the wonderful organization you made here. And I would like to show you, on behalf of the Jean Boris and Jean-Pierre Pignon, some data of the new update of the meta-analysis of the MACH-NC database, focusing here on concomitant or concurrent chemoradiotherapy. And this was to confirm the magnitude of the benefit of chemotherapy on survival as an endpoint, and to validate the effect in concomitant radiochemotherapy because of its uncertainties in the MACH-1 trial due to heterogeneity between the trials. And of course also in an attempt to increase the statistical power to allow subgroup and subset analysis. The eligibility criteria, of course, were trials properly randomized between 1965 and 2000 now, up to 2000, and there was the two arms, loco-regional plus chemotherapy, concurrent or concomitant chemotherapy, and loco-regional treatment alone. And the data collection was, on the one hand, updated individual data collections for all randomized patients from published and unpublished trials, and extensive checking and validation of these data. The statistical methods were, on the one hand, the intent to treat analysis, log-rank test stratified by trials, survival times used to calculate relative risk, and the absolute benefit calculated from baseline survival and response rates. We deal with 24 additional new trials comprising 5,700 patients. 10% of those were in an adjuvant setting, 5% in neoadjuvant, and most of them, 85%, in a concurrent setting. So altogether, there are now 87 randomized trials which have been included, and the database is now 16,640 patients, and mainly 2-arm and 3-arm trials and 2x2 trials. And so this is altogether, when they conclude the trials, 17,858 patients where have been done extensive analysis on. And you see that most of the patients are really the concurrent setting, and 14% in an adjuvant and neoadjuvant setting, 1/3 about. When you look at the site of the primaries, mainly oropharyngeal cancers and laryngeal and hyperpharyngeal cancers. And when looking at the tumor stage, it's a lot of stage 4 and stage 3 cases. And this is always the same in both arms, in the chemotherapy and the radiation arm. Now to the results. In the whole set of nearly 18,000 patients, with the endpoint of overall survival, you see that the chemotherapy adds some survival benefit, is a difference of 5%, which is highly significant. And this is with a median follow-up of nearly 6 years. And, have to go back. No. Okay. You see, in comparison with the old meta-analysis, there was a relative risk reduction of nearly 20%. We see no additional risk reduction with a new subset of patients. It's the same value, overall value of 19% risk reduction, of course, also statistically highly significant. And when you now look to these overall survival endpoint, with the concomitant trials, it's nearly 10,000 patients. There is an overall benefit in terms of overall survival of 8%, which is statistically highly significant. And it is an increase at 5 years from 27 to 35. And when you look, the heterogeneity, which has been present before, is now not anymore present. And so still, there is a survival rate difference in favor of chemotherapy at 5 years of the same order of magnitude, 6.6%. And when looking and a little bit differentiating according to the different treatment modalities here, surgery plus radiation, standard radiation or bifractionated radiation, you see that most profit or benefit one can correlate with the bifractionated radiation plus chemotherapy, and with surgery and chemotherapy, of course, the post-op setting, when you see that. But there is a benefit here of about, or a risk reduction of about 20%. And when you look at the combinations of chemotherapy, best is running a platinum-based chemotherapy with or without 5-FU. You see there is really no real difference in the risk reduction between with or without 5-FU, as long as platinum is in it. And when you go to the polychemotherapy with platinum basement or a monochemotherapy with platinum, you also see no real difference. So one can conclude that most important is this platinum as a component and not the other additive drugs, even also not 5-FU. So the conclusion is that we have a small benefit of chemotherapy on the survival, which is confirmed at the level of 5%. There is evidence of a higher survival benefit with a concurrent chemoradiation, which is also confirmed. The absolute benefit in the concurrent setting is 8% at 5 years, and even up to 11% or about 10%, you should perhaps take home, about 10% with cisplatinum-based chemotherapy. And there is a benefit of chemotherapy observed in the post-op and in the definitive setting, irrespective whether it's a conventional or hyperfractionated radiation regimen. So this is the acknowledgement. I just close with this here. And now another meta-analysis, which will be published also very soon by the Biomedical Cancer Journal, which is an online journal, has been done by my brother and myself and a statistician. And it also addresses the endpoint of chemoradiation, concurrent chemoradiation, but in another sense with a median survival benefit and not the survival benefit in terms of percentage at a certain time, which you will see here. You will see all these different studies with the total dose in both arms with the different days for overall treatment time. Here the overall treatment times were the same in both arms. And now you see here the different graphs, and you see there is a highly significant advantage for the concurrent chemotherapy and radiation, and this is in an order of, it's in an order of 13% at 2 years. This is the benefit, the additional percentual addition of survival at 2 years, and here it's the additional median survival, which is 12 months. And when you go to altered fractionated radiotherapy and concurrent chemotherapy with the same overall treatment time, these studies are here listed down there, and look at the results, there is also statistically highly benefit, with at 2 years a benefit of 14% additionally to the control arm, and which corresponds to 12 months additional median survival at 2 years. And the altered fractionation and concurrent chemotherapy with a prolonged overall treatment time, you know, the split cost studies, these are these 3 here, come up with also a result, but this is considerable less predominant, only 8% benefit and 8% also in median survival benefit. And when you now look at the median survival impact with the different drugs, you see 5 of you, 24 months, why ever. There are these old trials where there is a very good survival benefit. I mean, really in month and cisplatinum, carboplatinum, and mitomycin C down there. And when you see the reduction of the odd ratios, there is for hyperfractionated and conventional radiation. These 2 I did not address in the talk. This is a pure irradiation. Here we have to go to. This is the chemoradiation and the radiation alone, where there is a considerable reduction in the odd ratios and also with the concurrent setting. So what can we conclude from all this? Concurrent chemoradiation currently is the standard of care, I think, for inoperable head and neck cancer. For patients not amenable for concurrent chemoradiation, hyperfractionated radiation should be standard of care according to the American study, and also perhaps the study of Fu here, of course, and also perhaps cetuximab in the future. And when we look at the potential improvements of the therapeutic index, we can, on the one hand, look at optimized radiotherapy techniques, which is available with the IMRT, especially when looking at the reduction of xerostomia from the sparing of the salivary glands, and then small molecules, which I have added here. You know all about those, and perhaps some new cytostatic drugs, which could bring some benefit in the future. And I have, at the last slide, I have asked some questions. What is the optimal combination of chemoradiation with standard or altered fractionation? This has not been addressed yet. There is a study running in the US, and I don't know the results yet. Do late effects of chemoradiation compromise the therapeutic benefit in a sense of a lowering of the therapeutic ratio? And can the addition of small molecules additionally improve chemoradiation results? We already discussed this. And is there a definitive role of surgery, for instance, in a salvage situation after chemoradiation regimens? Thank you.